Hi, everyone. Thank you for attending today's presentation. When we talk about weight management, lifestyle intervention is the common phrase we hear day in and day out, right? And as clinician working in a referral center, we love to know how intensive of a lifestyle change our patient had undergone in the past or currently what they are doing. But what actually lifestyle interventions mean? Exercise and diet, eat less, move more. And what do you mean when we say intensive lifestyle intervention? Keeping these questions in mind, I'm here today to share with you my thoughts on this topic. I have set three main objectives for our lecture today. At the end of this session, you'll be able to describe the 6 pillars of lifestyle intervention for health proposed by the American College of Lifestyle Medicine. And together we will appraise the evidence of each lifestyle intervention category for weight management. In addition, we will review major trials definition on what it means by intensive lifestyle intervention and reflect on its meaning. With this objective, I hope we, as future clinical or research leaders in the field of internal medicine, bariatric medicine, and endocrinology, are able to evaluate, develop, and execute intensive lifestyle intervention at our capacity to help patients manage weight. As a start, I want you to reflect on these two cases. The first case is Mr. John, a 37 years old man, diabetes for 5 years, currently on basal bolus insulin with that amount of insulin level, on dapagliflozin 10 milligram once a day, semaglutide 1 milligram weekly, metformin 1 gram twice a day. So at the back of your mind, do you think John already received an intensive diabetes management? And how about the second case? David is a 37 years old man with obesity class 2, no other medical conditions, opted to manage weight by lifestyle interventions, eating around 1,000 kilocalories per day, portion control, 3 meals a day, and then jogging 30 minutes 5 times per week. What do you think about the second case? Is John practicing an intensive lifestyle intervention? Probably yes, maybe not. Before we dive further into each area of lifestyle intervention and their intensity, it's good to know the basic of lifestyle medicine. And according to American College of Lifestyle Medicine, ACLM, lifestyle medicine is the use of evidence-based lifestyle intervention. And they are, number one, having a whole food, plant-predominant eating pattern. Number two, develop a regular physical activity that is enjoyable and persistent, long-lasting. Number three is getting a restorative sleep, equip skills or seek help with stress management or psychological well-being. Number five is avoidance of risky substances like substance abuse, alcohol, tobacco, morphine, and other substances. And number six is form and maintain positive social connection. So these 6 areas are modalities delivered by clinicians to prevent, treat, and possibly reverse chronic disease. And speaking of chronic disease, obesity has been recognized as a chronic and complex disease by major health organizations. For instance, the WHO, American Medical Association, Canadian Medical Association, just to name a few. Therefore, the utilizations of lifestyle intervention is one of the major components in weight management as described in previous slide. Yes, it's just one of the components. Despite the whole lecture, we'll be talking a lot about lifestyle intervention, but I want to remind everyone present today that all lifestyle interventions help manage obesity, but lifestyle interventions are not all about obesity management. Keep that in mind. As you can refer to the picture over the right side, extracted from the obesity practice guideline, which includes pharmacotherapy and bariatric surgery. Moving forward with our presentation on lifestyle intervention, eat less, move more, diet and exercise. These are the common interventions discussed in weight management and many other chronic conditions. And for your information, the term nutrition and physical activity are now the preferred one in weight management because the diet, the terminology of diet has some negative connotation of being restrictive and not sustainable, while exercise sounds prescriptive and forceful. So let's start with these two areas of the ACLM pillars. The ACLM pillars on nutrition recommends choosing whole food, predominantly plant-based one that are rich in fiber and nutrients. Lots of fruits, vegetables, beans, lentils, grains, nuts, and seed. This nutrition pillar is vital to ensure general health, and it forms a subset of medical nutrition therapies in weight management. In the obesity guideline, there is a list of dietary approaches, as you can see from the slide, which have evidence for weight reduction. Part of the list is shown in the chart, and the medical nutrition therapy chapter in obesity guideline summarize numerous nutritional trials for weight management and look at the outcome beyond weight reduction. So for instance, in this chart, you can see there's a column for the benefit of diabetes control and CV benefit according to the types of diet has been studied. It's important to understand that in weight management, it's not all about the reducing number on the scale, but it's a meaningful and sustainable weight management to gain health in various perspectives like metabolic, physical, mental, and social aspect improvement. And it's important to realize that no one dietary approach is superior to another. In our practice as a future bariatrician, bariatric medicine specialist, it will be common that patient will ask us which is the best diet. And it's important to know that it's a vast study and there's no one dietary approach now is superior to another. The decision on which dietary prescription or medical nutrition therapy prescription should be individualized to patient clinical profile and preference to ensure a long-term adherence. And of course, if we do have a RD services available in the team or community, do refer to them. And to identify how intensive a dietary approach is some of the article will write very low calorie diet as less than 800 kilocalorie per day, 800 to 1200 kilocalorie per day as defined in a low calorie diet. So these are some of the intensity level of dietary or nutritional therapies approach. And before I bring you deeper into the realm of physical activity, I need you to understand two terminology. As in the slide, you can see there are two advice. They are definitely related to physical activity. The question is, what are they specifically talking about? So number one is a walk at park, 50 minutes per session, 6 times per week. And number two, let's just do some gardening use more stairs. So these two are the various physical activity advice or prescription that usually we give. The top one is an exercise prescription, though it is incomplete one. And the bottom one is called as NEAT, non-exercise activity thermogenesis, meaning you're doing your daily activities to increase the physical output. To put in simple, NEAT is the physical activity achieved in activity of daily living, while exercise prescription has 4 components to be fulfilled. Most of the time, clinician will give out NEAT rather than exercise prescription when we think back how we counsel our patient. Walk more, take your dog for a walk. So these are mostly NEAT. Either one is good because any form of physical activity is a good start to better health. Just now I mentioned about the 4 components in exercise prescription. So we use the FITT acronym to guide us. It's similar to how we prescribe medication. What medication, the dose, the frequency, and duration. FITT translate to types of exercise, intensity of it, duration or time for each session, and how frequent we want to do that. exercise. There are a few types of exercises, aerobic or cardio, resistance training, balance stretching.
Yeah.
And we can specify what sort of...
Oh no, this is an old cake.
We can specify what sort of physical activity like running, cycling, body weight, resistance band, etc., etc. The duration or frequency of exercise are self-explanatory. So in assessing intensity of exercise is a bit tricky because there are a few methods to do so. The commonest one is the RPE, rating of perceived exertion, or box scale. Basically means how short of breath are you while doing the exercise using a 10 scale point. So for example, moderate intensity is 5 points when you are breathing heavily but still can have conversations. So that's the intensity part of it. And other methods of rating intensity of exercises are metabolic equivalent task chart using maximum heart rate calculation and VO2 max, which we can explore after the session. And physical activity or exercise alone is not the best way to lose weight, as in obesity management. Benefits of physical activity goes way beyond number of the scales. So look at this chart in the slide extracted from the Canadian Obesity Guideline, which summarize the benefits of physical activity. The non-scale victories like cardiorespiratory fitness, metabolic improvement, mental health, mobility improvement were the repeated themes for benefit of physical activity rather than achieving a number in the weighing scale. Therefore, don't exercise to lose weight, but exercise to gain health. The next pillar is about stress. Stress can significantly impact someone's ability to maintain a healthy weight. We get high level of cortisol and we also exhibit unhealthy stress-induced behavior which cause weight gain. There are various origins of stressor in patients living with obesity, underlying medical conditions, work or relationship problems, and some majority of them will experience or internalize weight bias and stigma. These are some of the problem and stressor patients with obesity face. And the idea that patients only need willpower to eliminate stress and then manage weight is so wrong. But many healthcare providers and patients believe that. So in contrast, I think providing skill powers rather than expecting willpower to manage stress actually helps patients to lose weight better. And so about the psychological pillars, we have one whole chapter about it in the obesity guideline because it's also one of the major pillars in weight management and lifestyle management, lifestyle medicine. Other than the highlighted part on managing stress, the other behavioral intervention in these slides are useful. They help to reduce misunderstanding on the disease of obesity, provide structure and accountability in patient lifestyle, and develop problem-solving skills. These strategies helps in stress and also weight management. So there's one thing I learned from Obesity Medicine Association is that the mnemonic of a success in weight management is a SAME. Provide a structure, make sure accountability, provide a metabolic advantage through the use of medication, of surgery, and environmental change. So SAME. So these psychological pillars is vital in that sense. And from literature review, I can find one interesting RCT conducted at Athens, Greece. It compared the weight loss between patients with obesity intervened with 8 weeks of stress management program versus a usual obesity care by dietary and physical activity counseling. The 8 weeks program consists of progressive muscle relaxation, diaphragmatic breathing, and guided visualization. These methods are aimed to progressively patient incorrect perception about nutrition with healthier food habits and choices. So they try to correct the thinking about food, the feelings about food in this study. So the result is significant with a BMI of reduction 3.1 unit versus 1.7 unit in the control group. So it's a significant with p-value of less than 0.001. My opinion on this paper is that it's a small sample size and with a high dropout rate. And also there's an issues with subjectiveness on compliance. The next pillar is on sleep. The lack of sleep is definitely a stressor to our body, and it has a similar pathway in causing obesity as previously described. ACLM has listed restorative with improved sleep actually reduce weight. There are two papers I want to discuss which published recently. The first one is a RCT conducted in Chicago, found that increment of around 1 hour of sleep reduced energy intake about 300 kilocalories per day and resulted in around 1 kilogram weight loss over 2 weeks. And the second latest research paper that I've seen is that it's a small scale crossover RCT conducted at Mayo Clinic to explore the effect of sleep deprivation. So they admit the patient and deprive them of the opportunity to sleep. And with a restricted sleep opportunity down to 4 hours as compared to the usual 9 hours sleep opportunity, there was a significant increase of energy intake, body weight, and also abdominal obesity. So definitely sleep plays a big role in weight management. What I can infer is that sleep duration influence energy intake and probably the weight will be influenced. However, the study that I mentioned, even some review article only review the small scale study with a short duration of time. I cannot extrapolate the effectiveness of sleep extension in a long-term weight management outcome. And also not sure how many hours we want to aim for. There's no specific data for that. So at best, we can try to convince patient aiming for an 1 hour extension of whatever they are sleeping now, if they are feeling not restored from their sleep. So the outcome that patient should focus on as clinician is that patient has a refreshed sleep in the morning. And the next one is about substance use abstinence. So abstinence from intoxicating substances like alcohol, nicotine, drugs are definitely a good thing to maintain health. And how does this actually influences weight management? Alcohol and cannabis are the common substances described to cause weight gain. However, the evidence are somewhat conflicting. Recent prospective studies show that light to moderate alcohol intake is not associated with weight gain. Weight gain is more likely in heavy drinker, and conclusion from that paper, as listed in the reference, is alcohol intake may be a risk factor for obesity in some individual and likely based on many other factors. And one of the homework that Dr. Shao gave me is about marijuana use and weight. Some smoke weed, marijuana, they have increased appetite. So the reason is that cannabis or THC is stimulates CB1 receptor and increases calorie intake during acute exposure. But how about in long-term user? Sometimes we even see weight loss in those long-term cannabis user. And the possible explanation to such paradox is long-lasting down regulation of CB1R following cannabis consumption and reduces energy storage and increases the metabolic rates. But whatever it is, whether it's maintain weight, reduce weight, increase weight, substance use abstinence is definitely a good thing in a lifestyle perspective. And if you're interested to know about the research on cannabis and weight management, that in the past, there's one medication called rimonabant, which was studied, but because of a serious psychiatric side effect, it was withdrawn. And then the last pillar in ACLM is to form and maintain positive relationships. I divided it into doctor-patient relationship and patient-peer or patient-family relationship in the context of weight management. For each patient undergoing a weight management journey, we want it to be a positive and effective one. So our rapport with them is of utmost importance. In the initial consult, it's important to reduce any misunderstanding about obesity and to reduce internalized bias and stigma that patient carries. So I've seen many patients with teary eyes. I'm sure you guys have to, during their consult or follow-up, seems like a lot of pain that they endure. And of course, maintaining that rapport is important for therapeutic purposes. So long-term follow-up is a must, and I think it fulfills in the ACLM pillars in maintaining positive relationship between doctor and patient. And in the follow-up, we can address setbacks faced by patient in their journey, treatment plan accordingly, because no one size fits all. And sometimes it's about trial and error that we did. Many studies review the importance of family and peer support in weight management. Family members joining weight management program together, spouse and family members were some of the characteristics that predictive of a successful weight management. As for peer support, this systematic review and meta-analysis included 65 studies, reviewed the importance of peer-supported lifestyle interventions. So it pointed towards some weight reduction, not much. Nevertheless, I would say that the non-scale effect like psychological wellness, the feeling of support, and long-term adherence and learning of the skills in weight management are some of the important things that we want our patient to have and learn. So having said that, we have completed review the 6 areas available in the lifestyle intervention outlined by ACLM and discuss a little bit on the evidence in each area. And moving forward to the next part is to assess what intensive lifestyle interventions mean. And I searched the keyword ILI, IBT, intensive behavior therapy, and found these 3 major trials elaborated on lifestyle intervention for them. So I'm excited to be sharing with you about this. And reviewing protocol is so important for us as a future leader in this field, because when I'm back, you are back to your own province or country. Part of it is a weight management programming that we need to do. So the first study that I'm going to discuss about look ahead study is a multi-center RCT designed to determine whether intentional weight loss reduces cardiovascular morbidity and mortality in overweight individuals with type 2 diabetes. So it was a long-term study conducted from 2001 to 2012. It compared ILI, intensive lifestyle, with a standard diabetic care. About 1,800 participants in each group were enrolled. And 2 main objectives. Number 1 is to try to achieve weight loss of 7% and having more than 175 minutes per week moderate intensity exercise. So from the summary of the protocol here is that the first 6 months, there will be 1 individual and 3 groups visits with meal replacement shakes or bar around 2 meals plus 1 snack. So it's like a practicing of partial meal replacement with individual and group follow-up. And for the second 6 months, there will be 1 individual and 2 group visits per month. In total, there will be around 18 visits, and there will be a single meal replacement. For year 2 to year 4, there will be 1 individual visit plus 1 check-in through phone, emails, and or sometimes a snail mail. So total, there's extensive throughout that 2 years will be 36 visits plus 36 check-ins. So you can opt to go for optional group meetings or refresher group meetings. And sometimes if they have a national campaigns, the patient will be invited to. And from year 5 until the end of the study, there will be 1 individual visit per month and optional group meeting. As compared to the control group, which is the standard diabetes care education, year 1 to year 4, participant had 3 group sessions per year, so very sparse out follow-ups. And then year 5 onwards, annual group meeting. So about the individual and group meeting is the place and the time where the participant discuss about behavioral modification, and there's a module for it. So for the behavioral modification, the module was delivered either in group or individual setting. They includes the topics on self-monitoring, recordings about weight, food, and step tracking, how to structure meals, how to manage their negative thoughts, provide them with goal setting, problem solving skills, and to explain about body image and self-esteem, and how to manage in case there's a lapse or relapse in their weight loss journey. 1 year into the look ahead trial, intervention group had weight loss mean of around 8.5% as compared to the placebo group. They only have 0.6% weight loss. There's a significant difference of throughout intervention, despite intensive lifestyle participants regaining more weight. But the difference is still significant. The net weight loss was better as compared to standard diabetes care and education group, even after the weight regain trajectory in the intervention group. So the next trial that I'm going to share about is on DPP, Diabetes Prevention Program. So Look Ahead trial used this program as a base to build their protocols. So I would say DPP is sort of like the grandfather of all the major weight management program or trials. The main objective of DPP is to prevent or delay diabetes in those with impaired fasting or impaired glucose tolerance. It was randomized into 3 arms, one is intensive lifestyle, metformin, and placebo. The trial lasted for 3 years. The goal-based behavioral interventions were weight loss more than 7% and to achieve 150 minutes per week moderate physical activity. For DPP, it used individual approach by employing lifestyle coach. There are 16 session core curriculum over 6 months. Each session will last around 30 to 60 minutes. It consists of weighing, review records, with a topic presentation, identify personal barriers, and develop the next goal. Sounds like our stream program. And then there will be self-monitoring of weight, calorie, and fat intake plus physical activity. The dietary modification are purely food-based, calorie and fat focus. The target kilocalorie is 12 to 1800 per day. And for the physical activity, sometimes they will have a voluntary supervised physical activity sessions. And then during the maintenance, there will be group and individual sessions. Individual in-person visit at least once every 2 months with phone check-in once in a month. So there will be at least 3 group sessions per year. So the intensive lifestyle arm of DPP trial showed a good outcome in weight loss. 1 in 2 achieved target weight loss of 7% or more, and 2 out of 5 maintained such a level of weight loss at the end of the trial. So from statistical analysis, those that achieved targeted weight loss at 6 months had 3 times higher chance to maintain that at the end of trial as compared to the participant that did not. So here there's a theme, repeated theme here is about the 6 months is crucial in any lifestyle intervention. The third trial and the last one is a direct trial. It's the third protocol that I find related to intensive lifestyle intervention. It's an open label clustered randomized trial conducted among patients with diabetes in the UK primary care. The primary objective was to have a weight loss of more than 15 kilograms and diabetes remissions. So the trial involved 49 GP practices with final analysis of around 300 patients. So for this protocol, the intervention group followed the counterweight plus protocol. As for the control group, participants were managed as per routine diabetes care. In the first 3 to 5 months, the intervention group had full meal replacement. So the last 2 trials, they were mentioning about food focus, partial meal replacement. For direct trial, they are discussing on the use of full meal replacement, which come up to around 850 kilocalorie for up to 20 weeks. The types of replacement were like shakes, bar, or soup. So after full meal replacement phase, there was the food reintroduction phase over 2 to 8 weeks. And subsequently, in the maintenance phase till 2 years mark, participants were told to be on food focus management with an option of one meal replacement, so like a partial meal replacement as needed basis. The intervention was provided individually by nurse or dietitian at the primary care setting. In the first 2 phases, the follow-up were 2 weekly and then monthly in the maintenance phase till the end of 2 years mark. In total, participants had around 35 contact points with their providers. So the thing that I find interesting in direct trial is the rescue protocol. There's some statement about if the participant increase 2 or 4 kilograms from their baseline, what kind of meal replacement, whether it's a full or partial meal replacement as a rescue protocol to push down the weight throughout the trial. So the results was pretty amazing. 1 out of 10 remained more than 15 kilogram weight loss at 2 years after the full meal replacement program. And you are 7.5 times more likely to maintain weight loss more than 15 kilogram at 2 years than standard diabetes care. So active, regular interventions, full meal replacement in this lifestyle intervention has 7 to 8 times more chances of you to maintain that weight at the end of 2 years. And also 4 out of 10 remain no diabetes without any medication at 2 years after full meal after that program. And you are 26 times more likely to achieve diabetes remission at 2 years than standard diabetes care. And though only 10% of patients remain more than 15 kilogram weight loss at 2 years, but the non-scale victory of diabetes remission was fantastic at 35%. So the diabetes remission from this intervention is at a good rate in 2 year marks. And even without diabetes remission, the medication usage significantly reduced at the end of the trial. So based on the 3 intensive lifestyle protocols that we reviewed just now, I did some qualitative research on my own to identify the repeated themes and codes I see. Then I grouped them into these 6 distinctive themes. First and foremost is having a structure in a program style with minimum duration of 6 months. These are the things that I keep on mentioning. The 6-month marks is always there. And throughout the program, they have regular follow-ups, weekly in the initial phase or 2 weekly, and then slowly transition to a longer intervals, fortnight, monthly, and then appointment as needed basis. And the follow-ups were for troubleshooting of lifestyle intervention and discuss behavioral modification topics, be it in a group or individual setting. Then there were a big chunk of codes on calorie restriction, physical activity prescription, and behavioral change module delivery. Remember, there's some kind of modules involved here, except for direct trial. So the first 2, the DPP and look ahead trial, they're telling about module, topics, certain things to be learned. And few methods were discussed on the dietary approach, such as a low-calorie or hypocalorie diet, whether it's from food-based or meal replacement plan. Physical activity prescription range from 150 to 250 minutes of moderate intensity workout whether it's supervised or self-directed. And lastly, there's one more theme which I see not as frequent as the above five, but it's about multidisciplinary team, having one doctor, one dietitian, or a nurse is there with the doctor. So these are the teams, the last one that I realized. And speaking of having a team, weight management team, do you know that research has found a multidisciplinary approach is more likely to produce significant weight loss, which around more than 5% of initial weight. And there were two systematic reviews that shows that prove this. So the multidisciplinary team approach involved intensive behavior treatment with allied health professional, dietitian, nurses, psychologists, exercise physiologists, plus physician monitoring the patient throughout the year. And this approach was something that I found from the protocols that we read just now. And here is another one, research by the NHS and published by NICE guideline. Now we have an idea what intensive lifestyle programs or comprehensive program means. Just take a step back and look from a fragmented perspective. For each pillars, what do you mean by intensive? So for nutrition, we can gauge the intensity according to the how much calorie restrict and how long we provide this kind of calorie restrictions for the nutrition pillars. And for physical activity, we prescribe based on the intensity and the prescription based on FITT acronyms. And for stress, we must have a systematic behavioral kind of module deliveries. Then only I say is, yeah, you really practicing intensive lifestyle changes. And of course, if possible, have a peer or group support and have the regular follow-up. And it's not like you can come back anytime you want. We must set a intensive regular monitoring. If we can't afford, maybe monthly and then 2 monthly. And if we can do it, probably every 2 weeks until patient learn the skills in the lifestyle intervention. And sleep, try to aim for 1 hour increase from the baseline, or if the parameters and outcome the patient should look out for is restorative sleep. They feel much better after the sleep in the next morning. So I like to share what ILI, intensive lifestyle intervention, meant to me in 2 different perspectives. So I am a family doctor in a primary care setting. There are various limitations in my practice. So my intensive lifestyle intervention is somewhat limited after learning through this literature review and also through the fellowship program. I say as family physician, we should provide monthly appointment with focused weight discussion for at least 6 months. Okay, and of course, this patient is under our long-term care. We should follow them for life. But for weight management per se, minimum, I want you to do it 6 months properly, purely talking about weight every month. And for nutritional approach, I can include some form of partial meal replacement as option and prescribe basic exercise or physical activity based on the FITT acronym. And due to time constraint, I would prefer to refer my patient to the allied health professional available in the community to fulfill the multidisciplinary approach part. I can't do all the things together as a family doctor. And number 2 is the most interesting part. Dr. Xiao, Leaf Clinic, University of Ottawa are training leaders in the field of bariatric medicine or obesity medicine. And myself, now we are trying to be a bariatric medicine specialist. And my aim is to develop a referral center or center of excellence, just like Leaf Clinic, for obesity care. So the definition of ILI definitely will have some form of standard and mandatory thing that I want. I would want nothing less than DPP, look ahead, or direct trial. At least it's a structured, regular 2 weekly appointment with an option of doing partial or full meal replacements. And then I would want an in-house allied health professional to help me to convey the modules, behavioral modules, counsel for exercise, nutritional therapies, etc., etc. So, and I probably would want integration between in-person and virtual care too, because there's something going on now, and is the way to move forward. So these are my take from two different perspectives. So I have shared my view on how intensive lifestyle intervention looks like. What about weight management programming? So how about you? So I'm sure you fulfill one of the role here listed, and that will be your homework to think about it. In the last 40 minutes, I hope the information provided are able to fulfill the 3 learning objectives in this learning session. And if intensifying diabetes treatment is increasing or adding meds, I expect similar intensification for lifestyle intervention in obesity care, not just giving generic advice to eat less and move more, because we know both diabetes and obesity are chronic diseases, and we must treat chronic diseases aggressively and intensify management when indicated. Treat obesity like any other chronic diseases. So thank you everyone for the attention.